Hello, this is Dr. Michael Erdank. I am a faculty member at the Johns Hopkins University School of Medicine in the Division of Pain Medicine and an implanting physician on the Neuromodulation Service. This American Society of Regional Anesthesia and Pain Medicine webcast will cover the topic of implantable pulse generator site pain after spinal cord stimulator implantation. Spinal cord stimulators may be a useful form of therapy for patients with chronic refractory pain. There are, however, complications associated with this therapy. They may be hardware related, they may be related to lead migration, or in some cases, the patient may suffer from discomfort or pain at the implantable pulse generator site. Some of these patients may develop this as a function of becoming more active with their stimulators and losing weight. It's never a great thing to take a patient back to the operating room, but in these types of cases, at least it's an increased level of activity that leads to this. However, in some cases, this is due to inappropriate placement of the pulse generator or things that could have been addressed ahead of time that we can cover with regards to treatment, diagnosis, and prevention. I have no relevant financial relationships to disclose as part of this webcast. The scope of the problem has been described in the literature and ranges anywhere from approximately 1% to 12% when dealing with standard spinal cord stimulation. The data that you see from Brazelli refers specifically to sacral stimulation and may be a bit of a different situation. So the problem, although not completely negligible, should be relatively rare. The Neuromodulation Appropriateness Consensus Committee in 2014 addressed some of these issues with regard to IPG site pain. One needs exercise care when implanting in the presacral buttock area because there can be relatively little subcutaneous fat, especially superiorly and medially in the vicinity of the posterior superior iliac spine. Therefore, one might choose to work a little further caudad and lateral in the buttock area, avoiding the waistband and avoiding the area where the patient sits. Some have also advocated instead placing the IPG device in the anterior abdominal wall, where one may see a little bit more adipose tissue and therefore less of a chance of IPG site pain. Several treatment strategies have been discussed in a recent publication. Some have suggested the use of physiotherapy or neuropathic pain medication to help deal with the discomfort of an uncomfortable IPG site. Should those measures prove to be ineffective, then a surgical intervention may be required. If the device is in fact too superficial, then moving it less superficially may be required. The IPG device rarely may move within the surgical pocket, so use of suture fixation within the surgical pocket may also be helpful in this regard. Should the above be ineffective, then there is the option of either relocating to the abdominal wall as was previously discussed, or relocating the IPG over to the contralateral side for the patient. The above measures are usually quite effective, and permanent removal of the device secondary to implantable pulse generator site pain is rarely necessary. Some have advocated, as has been published, the injection of local anesthetic or corticosteroids into the region of the IPG, which is causing discomfort. I would approach this with a great deal of caution, however, because introduction of a needle into the area of the device or the leads really sets up the possibility of either damaging the device or introducing infection. When we discuss rechargeable IPGs, we need to find some sort of a happy medium where these can be placed. Should they be placed too superficially, then the risk of erosion or device protrusion is clearly more of an issue. They cannot, however, be placed too deeply because the recharging process then may become problematic. Taking care to employ preventative measures preoperatively may in fact be quite helpful in preventing this problem from occurring. Spending some extra time with the patient preoperatively to discuss the optimal location of the IPG site and to mark it may avoid belt or waistband associated discomfort with the IPG placement. Furthermore, discussing the patient's particular lifestyle, their dominant handedness may help you to ascertain which is the best side relative to ease of recharging if one is using a rechargeable unit, or if the patient sleeps on one particular side, one may choose to implant on the contralateral side. In summary, IPG site pain after spinal cord stimulator implantation is relatively uncommon. When present, however, it may cause pain, discomfort, or lifestyle limitation. The use of conservative therapy, the choice to revise or relocate the pocket, can in most cases prevent the need for explantation of the device. Thoughtful and open preoperative planning and discussion with the patient, as well as marking of the sites to use judicious locations, may lead to preemptive avoidance of these complications. Thank you. I can be reached for comments or questions at the email address seen here or via social media at my Twitter account. Thank you for your attention to this American Society of Regional and Anesthesia and Pain Medicine webcast.